Welcome to the Clinical Neurology with KD podcast Season 2. After the overwhelming response to Season 1, which focused on neurological localization for medical students, we are back with a brand new season dedicated to an exciting and often challenging topic of neuro-ophthalmology. If you haven't listened to Season 1, I highly recommend doing so. It will help you understand the fundamentals of neurological localization, which forms the foundation for this season. The podcast aims to help medical students enjoy the process of learning neurology by teaching it from a clinical perspective. This season will benefit medical students, medicine, ophthalmology, neurology residents, and consultants. Each episode starts with a pre-test of multiple choice question based on the topic discussed. The answers will be provided at the end of the episode. Study materials, illustrations, and clinical resources for the podcast are available in the show description and on the neurologyteachingclub.com website and Instagram page. I'm your host, Dr. Krishnadas NC, and let's get started. In this session, we will discuss the abducens nerve. As usual, we will begin with the pre-test multiple choice questions. Question 1. What structure forms the roof of the Dorillos canal? A. Petrous temporal bone. B. Posterior clinoid process. C. Gruber's ligament. D. Falx cerebri. 2. Which syndrome features abducens palsy, facial pain and ear discharge? A. Fowley syndrome. B. Gradinego syndrome. C. Millard-Gubler syndrome. D. Gottfredson syndrome. Question 3. A lesion in which location is most likely to cause bilateral 6th nerve palsy with 12th cranial nerve involvement? Choice A. Cavernous sinus. B. Clivus. C. Midbrain. D. Orbit. Question 4. In a patient with 6th nerve palsy with Horner syndrome, which feature best differentiates a cavernous sinus lesion from a pontine lesion? Choice A. Presence of abduction deficit. B. Distribution of facial sweating. C. Involvement of the medial rectus. D. Conjugate gaze palsy. Question 5. Which clinical scenario strongly suggests divergence insufficiency rather than an isolated 6th nerve palsy? Choice A. Esotropia at near and distance. B. Adduction deficit on duction testing. C. Full ductions with esotropia only at a distance. D. Sudden onset diplopia with medial rectus overaction. The abducens nerve supplies a single muscle, the ipsilateral lateral rectus, which abducts the eye. The abducens nucleus is situated in the mid to lower dorsal pontine tegmentum, separated from the fourth ventricle by the genu of the facial nerve, which forms the facial colliculus. The nucleus consists of somatic motor neurons. The 6th cranial nerve nucleus contains motor neurons that give rise to the 6th nerve vesicle and interneurons that give rise to the axons in the contralateral medial longitudinal fasciculus that innervates the contralateral medial rectus subnucleus of the 3rd cranial nerve. Thus, the 6th cranial nerve nucleus mediates the ipsilateral conjugate horizontal eye movements as well. The vesicle of the abducens nerve moves forward through the pontine tegmentum close to the parapontine reticular formation after exiting the nucleus. It lies medial to the facial nerve fasciculus and adjacent to the medial lemniscus and the corticospinal tract. The abducens nerve leaves the brainstem in the horizontal sulcus between the pons and the medulla lateral to the corticospinal bundle. In the subarachnoid space, the abducens nerve crosses the internal auditory artery and ascends the clivus in the prepontine cistern to reach the petrous apex. Then it pierces the dura at the dorsum sella and traverses the Dorillos canal between the posterior clinoid process and the petrous apex. Dorillos canal is the invagination of the dura in the petroclival region from the petroclival entrance point to the posterior end of the cavernous sinus. The petrosphenoidal ligament, otherwise known as Gruber's ligament, forms the roof of the canal. The petrous temporal bone forms the floor of the canal. The Dorillos canal is a passageway for abducens nerve from the brainstem to the cavernous sinus. It is a potential site of abducens nerve entrapment during trauma and raised intracranial pressure. In the cavernous sinus, the abducens nerve lies lateral to the internal carotid artery and medial to the ophthalmic division of the trigeminal nerve. The nerve lies below and medial to the oculomotor nerve. The abducens nerve is the only nerve that lies in the lumen of the cavernous sinus. Others are in the wall of the sinus. The pupil sympathetic fibers, from their course from pericarotid plexus to the ophthalmic division of the trigeminal, will travel a few millimeters through the abducens nerve in the cavernous sinus. The abducens nerve enters the orbit through the superior orbital fissure and the annulus of Sinn and supplies the lateral rectus. Clinical features. Patients with abducens nerve palsy will have binocular diplopia with horizontally separated images more when looking at a distance and in the direction of the weak muscle. There will be limited abduction in the eye of the involved side and the resting eye will be in adducted position. This esotropia will increase when looking at the side of the lesion. In patients with mild abducens weakness, the esophoria detected by a cover-uncover test on looking to the parietic side may be the only sign of abducens palsy, as the range of movements may be normal. In these patients, the misalignment is concealed by the brain's fusional mechanism and becomes apparent only when binocular vision is disrupted. Localization of the sixth cranial nerve palsy. Nuclear lesion. A nuclear sixth nerve palsy produces a horizontal gaze palsy to the same side rather than an isolated lateral rectus palsy, as the nucleus contains interneurons that supply the opposite medial rectus through the medial longitudinal fasciculus. The abducens nucleus lesion in early life will result in Mobius syndrome and Duane retraction syndrome. Mobius syndrome. Most patients have bilateral nuclear sixth nerve palsy. The most common ocular motor abnormality is bilateral horizontal gaze palsy. They may also have additional bilateral facial diplegia and other cranial nerve palsies including 9th, 10th, and 12th. The long tracts can also get involved, producing general motor disability and incoordination. It is a disorder of rhombencephalic maldevelopment. Duane retraction syndrome. Duane retraction syndrome is characterized by the narrowing of palpebral fissure and retraction of the globe on adduction. There are three types. Type 1, abduction is limited while adduction is normal. Type 2, impaired adduction with normal abduction. Type 3, abduction and adduction are both impaired. The abducens nerve is absent in type 1 and in some cases in type 3. It is congenital caused by the anomalous innervation of the lateral rectus by the inferior division of the oculomotor nerve. This results in simultaneous contraction of the medial and lateral rectus on attempted adduction, resulting in globe's retraction. The patients often don't have diplopia or esotropia in primary gaze. They also usually don't develop amblyopia. All types shows vertical deviation of the adducting eye through upshoots or downshoots during horizontal gaze. It is more common in females and affects the left eye more than the right eye, but it can be bilateral. It can rarely occur with acute causes like pontine glioma and following surgery for orbital cavernous hemangioma. An infarct in the anterior inferior cerebellar artery can lead to Foville syndrome, which affects the dorsal pontine tegmentum. This syndrome features ipsilateral horizontal gaze palsy resulting from involvement of the abducens nucleus, facial palsy due to damage of the fascicle of the 7th cranial nerve, and contralateral hemiparesis. Fascicular lesion. An anterior pontine paramedian lesion can spare the abducens nucleus and involves the fasciculus. It is commonly associated with the ipsilateral facial nerve and contralateral hemiparesis, a condition known as Millard-Gobler syndrome. Sometimes a small lesion in the pons can involve the abducens fascicle alone, resulting in isolated 6th cranial nerve palsy. Nuclear and fascicular lesions can have associated long tract signs like ataxia, Horner syndrome, and hemiparesis. The 5th, 7th, and 8th cranial nerves can also get involved in these cases. Nuclear and fascicular lesions may be due to infarction, hemorrhage, tumor, infection, inflammation, or trauma. An imaging, ideally an MRI of the brain, will confirm the lesion. Subarachnoid space. Lesions affecting the abducens nerve in the prepontine cistern may compress the ipsilateral corticospinal bundles, leading to contralateral hemiparesis and ipsilateral 6th nerve palsy. Compressions of the trigeminal nerve can cause ipsilateral facial pain. Lesions in the subarachnoid space can cause unilateral or bilateral 6th cranial nerve palsy. Any cause of raised intracranial pressure can cause abducens palsy. Cranial nerve 6 palsies are most common and classic false localizing signs. They are non-specific and do not necessarily relate anatomically to the central nervous system pathology that produces them. For example, a frontal lobe mass lesion may be the cause of raised ICT that causes the 6th nerve palsy. We assume that the pathology is somewhere in the course of the 6th cranial nerve when it is in the frontal lobe, nowhere near the 6th cranial nerve. That is why it is called a false localizing sign. Both idiopathic intracranial hypertension and hypotension can cause 6th cranial nerve palsy. All cases requires imaging, ideally a contrast-enhanced MRI and CSF study if the imaging is normal. Cerebellopontine angle lesions can involve the abducens nerve. Clivus. Combined 6th and 12th cranial nerve palsy usually suggest a clivus lesion. It is called Gottfredsen syndrome, and the etiology is usually ominous, like a nasopharyngeal carcinoma or clival metastasis. Rarely, subarachnoid pathologies can also produce this syndrome. Both sixth nerve lies very close to each other at the clivus. Lesions here can also cause bilateral sixth nerve palsy. Petrous apex and Dorillos canal. Based on neurological findings alone, it may be challenging to determine whether the nerve has been injured within subarachnoid space or in its petrous portion in the Dorillos canal. Associated trigeminal nerve involvement is more likely if the lesion is in the petrous portion. Other clinical findings may point to disease in the petrous bone, such as ear discharge from chronic otitis media or mastoiditis and deafness. An infectious or neoplastic process that spread to the tip of the petrous bone can lead to Gradinego syndrome. This syndrome features the triad of abducens nerve paralysis, facial pain, and ear discomfort or discharge. Additionally, trauma, inferior petrosal sinus thrombosis, vascular malformations, aneurysms, and tumors may also produce injury to the nerve at this location. Increased intracranial pressure often leads to dysfunction of the abducens nerve due to stretching of the nerve over the petrous tip, as the heightened pressure pushes the brainstem attachments inferiorly. Cavernous sinus and superior orbital fissure. The involvement of the other oculomotor nerves, retroorbital pain, and Horner's syndrome suggest a cavernous sinus lesion. Without Horner's syndrome, it is impossible to clinically differentiate a cavernous lesion from a superior orbital fissure lesion. The sympathetic fibers travel with abducens nerve for a short distance in the cavernous sinus. Unilateral abducens nerve palsy with Horner's syndrome localizes to the cavernous sinus, called Parkinson's syndrome. A pontine lesion can also produce sixth nerve palsy with Horner's syndrome. However, the cavernous lesion causes a postganglionic Horner's syndrome with the absence of sweating confined to the forehead. In contrast, in central Horner's syndrome due to pontine lesion, sweating is affected over the entire face. Trigeminal nerve sensory loss in V2 distribution with abducens palsy can occur due to nasopharyngeal carcinoma arising in the fossa of Rosenmuller and extending into the foramen lacerum. The etiologies of the cavernous and the superior orbital fissure lesions are the same and includes infective, inflammatory, and neoplastic causes. Orbit. The sixth cranial nerve can be damaged inside the orbital cavity to produce lateral rectus palsy. Proptosis, chemosis, and optic nerve involvement may also be present, along with other oculomotor nerve involvement. Trauma, tumors, and inflammatory process can cause abducens weakness in the orbit. Ischemic abducens palsy. Vasculopathy is the most common cause of isolated sixth cranial nerve palsy. The nerve can be involved anywhere along its course. Along with diabetes, patients can have other vascular risk factors like hypertension, dyslipidemia, etc. The sixth nerve palsy can evolve over 1 week and usually recovers spontaneously over 3 to 6 months. Recurrence is not uncommon. Older people with headaches should undergo evaluation for giant cell arteritis. Other causes of abduction impairment. Convergent spasm. Convergent spasm causes esotropia on lateral gaze and can be mistaken for sixth cranial nerve palsy. It is a functional disorder caused by voluntary convergence interrupting the lateral gaze. When the patient looks laterally, the sudden convergence stops the abducting eye midway, giving a feeling of lateral rectus palsy. The associated pupillary constriction is the clue that differentiates a convergent spasm from lateral rectus palsy. It can rarely be caused by midbrain compression. Divergence insufficiency. These patients have impaired abduction and esotropia when looking at a distance. They, however, have full abduction on duction testing. Patients have a horizontal comitant uncrossed diplopia at far while near vision is normal. It can develop as an isolated entity in an otherwise healthy person. Thalamic esotropia. Acute esotropia can occur in patients with contralateral thalamic infarct. Acute thalamic hemorrhage can cause bilateral asymmetric esotropia with severity more on the contralateral side. The esotropia is due to supranuclear disinhibition of the convergence pathway. Other causes of abduction impairment include medial rectus entrapment in orbital fractures, myasthenia gravis, orbital pseudotumor, and thyroid ophthalmopathy. Acute esotropia can occur as an initial manifestation of cerebellar disease. Multiple ocular motor nerve palsy. Multiple ocular motor nerve palsy can occur in lesions involving the brainstem, subarachnoid space, cavernous sinus, superior orbital fissure, or orbit. Lesions involving the neuromuscular junction like ocular myasthenia and muscle disease like progressive external ophthalmoplegia can also affect the extraocular muscles. We will discuss a few common disorders involving multiple extraocular nerves. Miller-Fisher syndrome. Miller-Fisher syndrome is a variant of Guillain-Barré syndrome characterized by areflexia, ophthalmoplegia, and ataxia. Most of these patients show anti-GQ1B ganglioside positivity. The third, fourth, and sixth cranial nerve contains a higher concentration of GQ1B in their ganglioside composition, making them vulnerable. Patients can have complete external ophthalmoplegia, including bilateral ptosis. Pupillary involvement is rare. A nerve conduction study reveals demyelinating neuropathy, and the cerebrospinal fluid will show albuminocytological dissociation. Patients respond well to IVIG or plasma exchange. Wernicke's encephalopathy. Wernicke's encephalopathy is characterized by the triad of confusion, ophthalmoplegia, and ataxia and is due to thiamine deficiency. Alcoholics, hyperemesis gravidarum, dialysis patients, cancer patients, and malnutrition due to any cause can produce this syndrome. Ocular findings can range from gaze-evoked nystagmus to total ophthalmoplegia. The oculomotor deficits in Wernicke's encephalopathy arise from selective neurotoxic damage to brainstem nuclei and cerebellar pathways critical for gaze control, driven by thiamine-dependent metabolic failure. Prompt intravenous thiamine replacement reverses ocular motor deficits within hours to days. Delayed treatment risks progression to Korsakoff syndrome characterized by irreversible memory impairment. Ophthalmoplegic migraine. Ophthalmoplegic migraine causes painful ophthalmoplegia, which usually starts in the first decade of life. The oculomotor nerve is commonly involved, though isolated trochlear or multiple ocular motor nerves can also get involved. Patients will have a history of typical migraine attacks. The third nerve palsy reaches maximum as the headache subsides and can last for 1 to 4 weeks. Some patients can have partial third nerve palsy. It is a diagnosis of exclusion and a detailed evaluation is necessary to rule out other causes. Patients are usually asymptomatic between attacks. MRI of the brain may show enhancement of the cranial nerves. Steroids are the mainstay in the treatment. Tolosa-Hunt syndrome. Tolosa-Hunt syndrome causes recurrent painful ophthalmoplegia due to idiopathic granulomatous inflammation of the cavernous sinus, superior orbital fissure, or the orbit. The cardinal feature is retroorbital pain accompanied by the palsy of third, fourth, and sixth cranial nerves. Other cranial nerves, including the fifth and seventh, can be involved rarely. MRI of the brain shows focal enhancement of the cavernous sinus. The differentials include infection, vasculitis, and neoplasm. Cerebrospinal fluid study and contrast imaging should be done in all cases to rule out alternate diagnosis. Steroids are the first line of treatment and pain usually responds within 72 hours, which also supports the diagnosis. The ophthalmoplegia improves over weeks. Around 40% of the cases can have recurrence. Refractory cases need immunosuppression and radiation. Carotid cavernous fistula. Carotid cavernous fistula is an abnormal vascular connection between the internal carotid artery, external carotid artery, or their branches and the cavernous sinus. They are classified as direct or high flow CCF if they arise from direct connection between the intracavernous carotid artery and the cavernous sinus. They are called indirect low flow or dural CCF if they result from indirect communication between the cavernous sinus and branches of the internal or external carotid artery within the adjacent dura. Traumatic CCF accounts for 70% of the cases. Spontaneous CCF accounts for 30% of the cases and is usually due to rupture of the internal carotid aneurysm. Clinical manifestations include pulsatile tinnitus, conjunctival injection, proptosis, and ophthalmoplegia due to cranial nerves 3, 4, and 6 compression. Vision loss may occur from ocular ischemia or glaucoma. Diagnosis requires neuroimaging. CT or MRI detects proptosis, superior ophthalmic vein enlargement, and cavernous sinus abnormalities, while digital subtraction angiography confirms fistula anatomy and flow dynamics. Treatment is endovascular embolization via transarterial or transvenous routes to occlude the fistula, preserving internal carotid artery patency. Corticosteroids may elevate inflammation pre-intervention. Untreated CCFs risk vision loss, cerebral ischemia, or hemorrhage from cortical venous reflux. Now let's see the answers for the pre-test multiple choice questions. Question 1. What structure forms the roofs of the Dorellos canal? A. Petrous temporal bone. B. posterior clinoid process, C. Gruber's ligament, D. Falx cerebri. Answer is C. Gruber's ligament. Gruber's ligament, also known as petrosphenoidal ligament, forms the roof of Dorillo's canal through which the abducen nerve passes. Question 2. Which syndrome features abducen palsy, facial pain, and ear discharge? A. Foveli syndrome, B. Gradinego syndrome, C. Millard-Gubler, D. Gottfredsen syndrome. Answer is B. Gradinego syndrome. Gradinego syndrome is classically a triad of abducen nerve palsy, facial pain, and ear discharges, usually due to petrous apex pathology. Question 3. A lesion in which location is most likely to cause bilateral 6th nerve palsy with 12th cranial nerve involvement? Choice A. Cavernous sinus, B. Clivus, C. Midbrain, D. Orbit. Answer is box clivus. A clival lesion may involve both abducen nerves as they run near to each other in the clivus and hypoglossal nerve, causing Gottfredsen syndrome. Question 4. In a patient with 6th nerve palsy with Horner's syndrome, which features best differentiate a cavernous sinus lesion from a pontine lesion? Choice A. Presence of abduction deficit, B. Distribution of facial sweating, C. Involvement of the medial rectus, D. Conjugate gaze palsy. Answer is box distribution of facial sweating. Cavernous sinus lesion causes postganglionic Horner's syndrome with sweating spread except for the forehead, while pontine lesion affect entire facial sweating. Question 5. Which clinical scenario strongly suggests divergence insufficiency rather than an isolated 6th nerve palsy? Choice A. Esotropy at near and distance, B. Adduction deficit on duction testing, C. Full ductions with esotropia only at a distance, D. Sudden onset diplopia with medial rectus overaction. Answer is C. Full ductions with esotropia only at a distance. In a divergence insufficiency, ocular motility is normal on duction, but esotropia is present only when viewing distant objects, not near. This helps to differentiate it from true lateral rectus palsy. Thank you for listening to the Clinical Neurology with KD podcast. We value your feedback and it motivates us to keep podcasting. Please subscribe, rate, and review the podcast if you find it beneficial. You can follow the Neurology Teaching Club on Instagram, Facebook, or X for exclusive visuals related to this podcast. To receive new episodes directly in your inbox, subscribe to our newsletter at neurologyteachingclub.com. Please note that the podcast and online content are meant for medical education only and should not be used to guide clinical decision making or treatment. You can find more episodes on Apple Podcasts, Spotify, Amazon Music, or wherever you enjoy podcasts. This is KD signing off. Until next time, spread knowledge.